Hello, Connecticut, and welcome to the Paid Leave Podcast. The title basically says it all. I'm Nancy Barrow, and I will be delving into this new state program and how it can help you and your family. This podcast will give you information you should know about Connecticut paid leave and maybe just a little bit more. Connecticut paid leave brings peace of mind to your home, family, and workplace. Welcome to the Paid Leave Podcast. Today, we're talking about hospice care and what it does to help families in a health crisis. Connecticut paid leave gives you up to 12 weeks of income replacement to take care of your own serious health condition or that of a loved one. And both my parents used hospice, and I can't tell you how much it helped all of us. And sometimes that can be a few days that they need you, a few weeks, a few months, and sometimes longer. My guests today are going to help us understand a little bit more about hospice and what it can offer families during a difficult time. Joining me is Dr. Ross Albert, who is the Hospice and Palliative Care Director for Hartford Healthcare at Home. And thanks for being here. I really appreciate it.
Thanks for having me. I appreciate it.
Also joining us, hospice volunteer Stephanie Annino, who has volunteered for 14 years, and she provides respite for caregivers and also can be a friendly visitor to patients. And I hear you sing and dance. I hear you do everything.
I do. Yes, I do. Thank you for having me.
And I also read that you did some pet therapy with your dog, Kate. What kind of dog is Kate?
She's an English setter, and she's a great dog. She aged out of the program, but it's a wonderful, as you know, animals, it's an amazing bond that they have with people very quickly, and it was very rewarding.
Yeah. Well, welcome to the podcast, Stephanie. I'm excited to talk to you. Dr. Albert, can you tell me the difference between what hospice is and palliative care? Is there a difference?
There is a difference. It's a great question, and it's something that there's a lot of confusion and misunderstanding around. Hospice is really the field that came first. Hospice started in the U.S. At least. It came to Connecticut first, and is focused on caring for patients, for people and their family towards the end of their life. It's a Medicare benefit that was created that does a lot of really innovative things, actually. Say what you will about Medicare, good or bad. It's actually the field for hospice. It focuses on a team-based approach to caring for patients. So doctor, nurse, volunteers, social workers, spiritual care, home health aides, all part of the benefit. And focuses on that team approach to support people. The biggest things around hospice care would be that it's focused on people who have a predicted life expectancy of 6 months or less. We know we don't have a crystal ball, but we have some medical data to support that when we sign somebody on to the benefit, that's at least the best estimate we have at that time. And then also that people who are pursuing hospice care are foregoing more aggressive, invasive interventions. So they're not looking to go back and forth to the hospital or to go through chemotherapy, which might not, at that point be effective anymore, things like that. So it's not about taking things away. It's really the idea that the benefits, the burdens are bigger than the benefits at that point. So we're foregoing those things to focus on the quality of life. Palliative care really came from the recognition that people were getting great care through hospice care. And what if we gave people that type of team-based supportive approach upstream earlier in their care? So when someone was still getting their chemotherapy or their advanced heart therapy or whatever it might be, could they also benefit by having a multidisciplinary approach to support them while they're getting those interventions? And that's what palliative care is about. It's about people who aren't just in that last 6 months of life, and it can be given to people while they're getting their disease-directed therapies.
I know that you said 6 months or less if the diagnosis came from their doctors, but what if someone didn't decline as fast as they thought? Do you still stay longer than 6 months, or do you reassess, or how do you keep continuing the care if it's going longer than 6 months?
Yeah, it's a good question. And again, some diseases, some people, we have a pretty good estimate, and some people we think we know, but we're not always sure.
Right.
So Medicare, again, makes us reassess over the period of time. So we follow people and do a sort of a certification at 3 months in, and then at 6 months again. If somebody finds their way to 6 months into hospice care and they're still clearly declining, if at around that 6 month period we look at them and we say this person still has a very limited prognosis or life expectancy, we have data to support the idea that maybe they're losing weight, or they used to be able to walk and now they're bedbound, things, concrete things that allow us to certify that somebody's still appropriate for hospice care, then we do that. Mm-hmm. And then for people who really did stabilize, sometimes we sign people on right after a hospital stay, and that's sometimes when people are at their worst. And then we incorporate hospice care. We have people at their house where they want to be. We have amazing support and care and volunteers and, everybody supporting them, and they do better. And then, over the course of that 1 month, 2 month, 3 month, we find that they're actually back to the baseline they were before that hospital stay or whatever it might have been. And that's a person who might sign off, and sometimes we might even call it hospice graduation. But, the goal here is that it's not, negative, that it would be to pursue what would fit their goals at that time. So to give them the right care for the right, stage of their life.
And can hospice be in assisted living or in the hospital or at home? Can it be all those places?
It can. So I learned from my mentor, hospice is a thing, not a place. And so hospice is a strategy of care that can be done. Most often it's in people's homes, but just like you said, assisted living, nursing homes, there are some dedicated hospice facilities, but not many of them in Connecticut. And then for people who need very sort of aggressive IV medications for their symptom management, they can even do hospice care in the hospital, although that's more rare.
Yeah. What services does hospice include? I heard you guys do some music therapy, and there's lots of different things that you offer.
Yeah. So there's pieces of hospice that are sort of mandated, and there's pieces that are unique to different agencies. So the mandated parts, again, these are good things when I say mandated, but it's this team-based approach. So that every hospice has a medical director, which is, a physician. Every hospice is going to have nurses, RNs and LPNs who are going to go to people's homes, social workers, spiritual care providers. And I emphasize spiritual care, not, a priest or a rabbi specifically, but it's somebody who is going to meet that person where they are in their faith and in their spirituality. We have home health aides in some limited hours for people, and that kind of ties into this discussion around caregiving that we're having today, and then the volunteer support that we have. So all of those pieces are actually part of the Medicare sort of legislation, I guess, if you will. And then the really amazing thing is that hospices will have unique characteristics. So ours, for example, at Hartford Healthcare, we do have a music therapist who is specially trained in connecting with people and supporting them through their journey through music. So different from a music volunteer, which we also might have, but this is somebody really specifically trained to do that. Different hospices also have different levels of veteran support as well, and I think that also is something really unique to different agencies as well, to provide extra care.
And what do you think sets your hospice care program apart from the others?
Probably every hospice would say this, but our people are remarkable. We've lived through COVID and we've lived through taking care of people and have had to be creative and engaged and passionate about taking care of people. So I'm just going to say that's definitely my first answer, is just the people that we have working for us are amazing. I think what's really unique for us is, Hartford Healthcare is a big entity now. We've gotten bigger and bigger over the last decade. And what we've done in doing that, I think, is we've grown and been able to offer more services and more care, really across the whole state at this point, which is really exciting. It's almost 400 people a day that we're taking care of. But also, I think what's unique is that each region has its own local office. So we feel to the patients and families like a small mom and pop hospice. And I think that's a hard needle to thread. And I think we've done a really good job of being big and offering more services because of it, but also feeling local. And I think we've done a good job with that.
Dr. Albert, when you're dealing with people at the end of life, that can be very emotional. How do you take care of yourself and the volunteers? Like, how do you do that? Because it's very, very stressful and emotional when you're dealing with someone at the end of their life.
Yeah, I'll give some answer, but maybe, and I don't want to jump the gun, but maybe that'd be good also for Stephanie to also talk about too, is just talk about her experience too. But I'll keep blabbing as well. But it's important to, I think, do a few things. It's important to honor the people that we have dedicated ourselves to taking care of and connecting with and supporting. Our team gets to know these people in their homes and their families in their homes. They get to, see their pets. They get to, look at all the pictures on the wall. And so when they pass away and when they're going through their journey, it's an emotional thing. And so one of the things we talk about our patients each week in an interdisciplinary meeting that our whole hospice team has. And so just simply talking about it and giving it space to be able to honor those moments, I think is really important. And I think helps us to deal with our own emotions around that. The other thing is, honestly, is also, disconnecting and connecting with the things, whether it's, we talked about a therapy dog, but whether it's, our families, our pets, our whatever, it might be. For me, it's, getting into some of the trails and putting my phone down and escaping for a little while. That's, or playing with my kids. Those are, for me, the way to disconnect and to separate too. I think that balance of acknowledging those emotions, but also being able to separate from it, at different times, just to kind of unplug for a bit is always healthy.
Do you like doing the hospice aspect of it?
I do. I like the team-based approach. I like, you have to kind of be a little bit of a nerd about it, but I like the medicines involved and some of the things around that. I get to go to people's homes. I do, the nurses are in terms of the medical people that, they're going and being my eyes usually, but I do get to go, which is
I didn't know that.
Yeah, it's not a lot, but I do get to go, and it's always, I walk out like Stephanie said, like it feels so amazing. Like yes. I feel better for going.
Yeah, and Stephanie, what do you think? How do you kind of regroup, because you are very close to the whole situation and the families?
Right. I view this time of their life like in the circle of life, and it's just a very special time in the process of our life. And I feel very grateful, and I feel honored that they have me help them and be in their home. And I actually learn so much from the patients and the families. And I get, how they say you get more than you give, like with volunteering. And it's so true. It could not be more true. But people ask me many times, well, isn't that sad, or isn't that really depressing? And honestly, I feel like it can be very uplifting experience, because it's allowing this time to have a good goodbye for these families. Mm-hmm. It's a chance to be able to, to talk about things that are important to them, and their fears even about what's next to come. And anyway, I guess I find it more, believe it or not, uplifting. I feel like it makes my life more joyful. And I just feel like hospice is just such an amazing, special time in the circle of life, really.
It is. Both my parents were in their homes when hospice came in, and both times medications were used for pain. Is that something that you, Dr. Albert, do, or are the nurses allowed to do that as well? Dispense medication?
So when the people we take care of have symptoms, and I do think it's always worth saying to people, there are a fair number of people we take care of who never have any symptoms at all, and who are very comfortable and who are peaceful, and that's their journey. Yeah. Others certainly might have symptoms and discomfort. So I every once in a while hear people worry, am I destined to have pain or symptoms? So when somebody has symptoms or whether it be pain or any other symptom, the nurse who's supporting the patient will connect either with me, the medical director, or when you're on hospice, your own attending doctor, generally your primary care doctor, your oncologist, they're also involved in your care. And so they'll reach out, the nurse will reach out either to them or to me for prescription, for guidance on what to do. So the nurse isn't making that choice on their own, but they're acting generally as the physician's eyes more often than not. And so then they'll collaborate together, and then they'll collaborate with the family to make a good plan and have a plan to either treat somebody's symptoms in that moment or how to prevent symptoms by maybe giving medication more regularly.
Yeah, and it's wonderful that they can stay at home and they don't have to go back to the hospital to get that. I think that that's what's really wonderful is they can be at home and comfortable with their family around and feeling a little bit more safe and secure.
Yeah, absolutely. And a lot of the medicines we give even are, they're meant to be easy to give. So ideally we're giving things that are either sometimes pills if people, are still swallowing and taking food and like normal, but if they're feeling weaker or more tired, we even have more concentrated liquid medicines that are almost given like when you give a baby a drop of Tylenol, you're giving that little drop of medicine under the tongue for your, the family member.
Right. Does hospice offer bereavement services or support groups, post the death of a patient?
We do. Every hospice agency actually, it's part of the Medicare hospice benefit is a year of bereavement support after somebody passes away. And so that looks different depending on the agency and where you live and things like that. But for us, that's our social worker and spiritual care team reaching out, connecting with people after their loved one has passed away. It's generally tailored to the needs of the person. So there are some people who sort of the spiritual care person might check in once and the person says, I'm okay. And they might decide, okay, you'll connect if you need it. Right. And then there's other people who have more intensive bereavement needs or grief that they need that additional support as well. And then the other last piece of that is our team also collaborates with the hospitals within Hartford Healthcare because they have some of their own bereavement support groups. And so sometimes we'll also sort of collaborate with them as well.
That's fantastic that you offer that a year after. That's really wonderful. We're an aging nation and state. Are you finding the need for hospice growing in Connecticut? And do you treat people with late stage dementia or Alzheimer's as well?
We do. So without a doubt, the numbers of people over 65 in America are, growing rapidly. And right. I forget the statistics exactly, but so in parallel with that, I would say we are seeing more people who would benefit from hospice. Of course, hospice has to be consistent with somebody's goals, and it's if somebody is focused on that type of care, then hospice might be appropriate. So we definitely see it. I think one of the biggest challenges we see in the context of hospice and diseases like Alzheimer's or other types of dementia is it can be very challenging to predict somebody's life expectancy in those contexts. So people can have a long decline as opposed to somebody with maybe a really angry cancer that might be a much shorter period of time. So
would you start with palliative care then, most likely, and then?
Yeah, that's exactly it. So, for example, not just in dementia, but in Hartford, we have our movement disorders group taking care of people with advanced Parkinson's. And so that is a person who might really benefit from more of a palliative approach, supporting their physical therapy, their speech therapy, their mobility for as long as they can, because that's probably consistent with their goals, even if they're not potentially looking for aggressive, hospital stays and things like that. But then over time, if maybe it becomes too hard or if their body just, won't allow that anymore, then that might be the time to transition to hospice. You
mentioned sort of medical wishes or maybe people should talk about this with their family, like a DNR. My mom had a DNR, which is do not resuscitate, or healthcare proxies. I mean, why do some families not want to talk about it? I know death and dying isn't something that you really want to bring up at the dinner table, but it's really important when you can't speak for yourself, that someone knows what you want, your directive. Do you think that hospice should be included in their advanced care planning?
Yeah, it's a really good question. So yeah, we don't talk about it enough. We don't talk about it early enough, for sure. And sometimes it's because the physician or the medical team is not thinking to talk about it or doesn't feel comfortable talking about it. Sometimes it's because the family doesn't feel comfortable talking about it, or,
Yeah.
and then other times the patient is not interested in talking about it. So it's a whole spectrum of reasons why the conversation doesn't happen enough or soon enough. So, when people have conversations, I think anytime they can talk about their goals is important. Anytime they can talk about, what's important to them. So I think one of the important things when you talk about somebody's wishes is yes, it's important to talk about hospice, and it's important to talk about things like DNR and code status, things like that. But it's really important to think about just like, what's important to you? And I think, for example, if somebody says, it's really important to me as I get further along in my disease to be home as much as possible, to be comfortable as much as possible, to have my family supported. To me as a hospice person, I say, geez, that sounds like hospice, but
Yeah.
but maybe their goals are to fight, with as much medical intervention and hospital stays and other things as much as they want. And again, that's not wrong either. I think the what's wrong, if you were going to call it that, is that if somebody never gets a chance to talk about their wishes.
Sure. Yeah. And I think there's icebreakers too. I heard that there's like a card game that you can play that actually talks about, like, starts that conversation.
Yeah, so there's a whole bunch of interesting ways to try to talk about your goals. So April 16th, the day after tax day, is that right?
Yeah.
Is National Healthcare Decision Day, and the irony there is because it's like death and taxes, you can't escape it. So that's
Right.
But it's meant to be a nudge for people to talk about their wishes. People talk about it actually. I forget the movement, they talk about doing it the day after Thanksgiving also, because it's a day when you're all with your family and you might be able to talk. And yeah, there's a card game that you can get, I think even on Amazon, called Go Wish, which is a way to actually stimulate some of those conversations. There's a packet it's kind of driven through some faith-based groups, but it's not at all faith-based. It's called 5 Wishes, which is another sort of provoking thing that is not meant for you when you're talking to your doctor, but it's just for families talking about what's important to them. And again, it comes down to sort of who do I want to be around me? Who do I want to speak for me? Whether I prioritize, time versus symptom management versus independence, things like that. So
Right.
it's that general picture, because like you said, if you have a named healthcare representative, so if you can't speak for yourself and someone's going to speak for you, you can't predict every choice, but at least if you give them a framework to make choices, then they'll be able to speak the best for you.
What do caregivers tell you about getting a little time and space away when they're going through such a hard time taking care of someone at home that they love so much?
Yeah, I mean, it's invaluable to them. They can't even express how grateful they are. And it's just simply offering to stay with the loved one for 2 hours a week, basically. And they get a chance to get out of the house, go for a walk on the beach, or even just doing grocery shopping and not having to worry about what time it is. And it just gives them a time out, and they are so grateful. And it just seems like such a little thing that I can do to help. And yeah.
But
anyway,
when you're in the midst of it,
Yes.
it's so consuming for the caregiver, and you coming in even for
Yes.
2 hours is so important for them to be able to, I don't know, do some chores that they need to do.
Exactly.
It's really
Exactly.
wonderful. What was
Thank
your
you.
volunteer training like?
Well, the hospice did do a very good job of, first they interviewed me. I felt like I was applying for a job,
Right?
And then they were very careful, very sure about you. And they wanted to make sure that you hadn't had a close person die very recently in your life, because they wanted you to be in the right place to be able to help. And I just remember there were classes that we took. They had classes, I'd say probably 6 classes. I don't remember. It was a long time ago, but they did have classes for us. And I think it's one of these things where it's also just, I mean, it's just going to happen naturally, like when you're there with the families and stuff. You do sort of learn by doing too, of course.
Yeah, right. And what do you think a volunteer for hospice, like the qualities they should have?
Honestly, just being able to be present, being able to hold somebody's hand. I just find that it's just remarkable, just touching and holding somebody's hand or, brushing somebody's hair. It's just these little things. But I guess just being able to be listening and be patient. And I think anybody could benefit from volunteering. It's such a rewarding thing to do.
So how did you get to start singing and dancing for people?
Okay, so this story, oh my gosh. So I am like I said, I'm learning so much, but I was visiting a patient with dementia and it was just so quiet. There was nothing to talk about. We just were sitting there and I was thinking, I can just sit here with her, or let's see, I wanted to try to connect on some kind of level with her. And I just simply started singing and I noticed she just like lit up and then she started clapping for me. Like I was like a famous actor or something. She's like, yay. And then when I started dancing with her too, I just had so much fun with her. And it was just so, so wonderful to see her, come to life, smile. Smile even. Yeah, it was really fun. It's fun. It was a great experience.
It seems like you kind of read the room, and what they need.
Yes, I was definitely outside my comfort zone, but but now I'm also like with another woman, I'm singing with her now, some old songs that my grandmother taught me, and they remember all the words.
That's amazing. Isn't that amazing?
It is amazing. Oh, this is the really funny thing. The woman I was talking about before, I would forget words. I could remember some of the words to these songs. And then I go, oh, I just can't remember. And she said, it's okay, honey. She goes, it'll come. You'll remember. So it's like role reversal.
Is there anybody that sticks out in your mind? I mean, have you worked with younger people and older people?
Yes, so that's the hardest thing.
Yeah.
Of course, is when you have an untimely death.
Mm-hmm.
And I have worked with someone in their 30s, but I just learned so much about life from her. Oh my gosh, it was such a blessing to have known her and her whole outlook on life. And she wasn't afraid to die, and her whole family was amazing, but. It was very hard. Her mother was there caring for her. So, you're comforting her mother. What I love about hospice is you're helping the entire family.
Mm-hmm.
And it's a whole network of people helping. And, it takes a village.
It sure does. And it's not like you're a doctor or dispensing medication, but what you're dispensing is really quite invaluable.
Absolutely.
And it's just wonderful. And this is what I love about Connecticut paid leave and the fact that we can give 12 weeks of income replacement to a caregiver, which will also alleviate some of the grief that you see and the tension and the stress that they're going through when someone that they love is in a serious health issue. And, they can take the whole 12 weeks at one time, or they can do intermittent leave, or they can do reduced schedule if they're still working, and it's nice that they don't have to choose between their job and money and taking care of someone that they love. It's wonderful that we have it in Connecticut.
It's fantastic.
Yeah.
And it's really important because one of the things, not to interrupt, is just all those things that hospice does right, in including all these different pieces. The one thing that the Medicare benefit doesn't do is to have somebody in the house 24 hours a day. Hospice is available 24 hours. You can call them at 2 a.m. and say, somebody's feeling nauseous or having some pain, but they're not physically there all the time. And so this is that traditional model of families caring for families with the support of an amazing hospice team. So having that ability to do it and not have that strain around personal finances and things like that is just huge. It's so important.
Yeah.
Well, please,
Yeah.
let's get together so we can get your caregivers the information about Connecticut paid leave benefits. I want them to understand what's available to them because I think that's really important for the caregivers.
Absolutely.
I'd love to get together with you to do that. So, Dr. Ross Albert, the Hospice and Palliative Care Director at Hartford Healthcare at Home, and hospice volunteer Stephanie Annino, thank you both for being on the podcast. You're pretty special people. Dealing with the end of people's lives isn't easy, but you certainly make it a lot easier for them and their families. And thank you for giving people dignity and the ability to be at home at the end of their life. I think that's really important.
Thanks again for having us.
Yeah, thank you.
Appreciate it.
Thank you.
Nancy.
For more information about Connecticut paid leave or to apply for benefits, please go to ctpaidleave.org. This has been another edition of the Paid Leave Podcast. Please like and subscribe so you'll be notified about new podcasts that become available. Connecticut Paid Leave is a public act with a personal purpose. I'm Nancy Barrow, and thanks for listening.